Hi guys, welcome back to Cosmetic Surgery and Coffee. This is episode number 2, breast augmentation, all the things you want to know. I'm Dr. Manish Shah. I'm a Denver board certified plastic surgeon, and this is the lovely Misti Mills, and we're going to be teaching you guys about breast augmentation and a few of the things that you need to know about that particular procedure. And we're also going to start off with our first segment, which we call Did You Know? Now, today's Did You Know is about vitamin C. Do you know much about vitamin C? Now, vitamin C is probably one of the best vitamins that you can either ingest or put on your skin. So let's just talk about some of the benefits of this particular vitamin. Vitamin C is known as ascorbic acid. Ascorbic acid is a water-soluble vitamin. You don't need a lot in your diet every day. Recommended daily allowances are under 100 milligrams. I take 1,000 to 2,000 milligrams a day. Anything that my body doesn't need, because it's water soluble, I pee it out, so it's not that big of a deal. I take it both orally and I put it on my skin. In fact, my Alchemy medical grade skincare line has a vitamin C and E serum called Enlighten, and that's what's on my face today, and I love it. It's good for antioxidant protection, it's good for brightening the skin, and it's a very small, lightweight acid, so it easily exfoliates. It's not quite as powerful as a Retin-A, but we're in Denver and there's a lot of sun, so it's a little easier to wear on a daily basis. Now, vitamin C in a dietary standpoint has a number of benefits. Vitamin C is the most important vitamin for the creation of collagen in the body. Two major types of collagen are collagen type 1 and collagen type 3. They make up many of our structural proteins in the bone, skin, hair, and soft tissues of the body. Collagen deficiency from vitamin C deficiency causes wound healing problems and breakdowns in those tissues. So vitamin C is very, very important for normal wound healing. It's also very important as an antioxidant. And now antioxidants are chemicals that we can take into our bodies that basically sponge up those nasty things called free radicals. Now, free radicals are chemically charged particles that are running around damaging DNA, damaging cell membranes, causing breakdown in normal tissue and normal cellular structures and functions that can lead to other diseases. There's some data that vitamin C can be protective against the development of certain kinds of cancers. It's obviously well known that it supports healthy skin, hair, and nails. And there's even data talking about how vitamin C will, while it won't stop the common cold, it will reduce the severity and it will shorten the time that you're suffering from the common cold. There's other data talking about how vitamin C is protective from a cardiovascular standpoint in terms of keeping your blood vessels soft and less filled with atherosclerotic plaque. And there's also some data that it helps your blood pressure medicines keep your blood pressure low. So it's a really good vitamin. You should be taking it on a daily basis. And where can you get this? Obviously, topical vitamin C you can get in your skincare creams. You can also get vitamin C supplements, and we usually recommend the Ester C, the 500 milligram tablets, because Ester C is a little nicer on your stomach, less likely to cause you to have gastrointestinal side effects. But if you are somebody who likes to get their vitamins and minerals from your diet, which most of us should, and if we're eating good whole foods, you're going to be getting a lot of good you're going to be getting a lot of good vitamin support and supplementation. But the bright vegetables and the bright fruits, so oranges, limes, red peppers, green peppers, dark leafy green vegetables like spinaches and broccolis, these are all good sources of vitamin C. And of course, they've got a lot of other great vitamins, minerals, and fiber in them. So vitamin C is a really good, it's a really good vitamin to have in your daily armamentarium, probably one of the best ones, something that I do every day as part of an anti-aging and overall healthcare regimen. In the description below, there'll be a link to the article that I found online just talking about these benefits, and I hope you check it out. So, shall we talk about breast augmentation, Misti?
Yeah,
all right.
For sure.
So, as you know, I'm a board-certified plastic surgeon, and breast augmentation, depending on the year, is either the most common or the second most common cosmetic surgery procedure performed in the United States. And breast augmentation can be done, performed as a procedure by itself just for women who've got small breasts and want them to be made larger. Sometimes it's also used in conjunction with other breast procedures like breast lifting or breast cancer reconstruction, because there's an overall derangement or malposition of the breast, and a woman, and in some cases men, want a more authentic, natural, youthful looking chest wall. And so there are a number of options for the procedure, and we're going to talk about all that today.
All right. That was actually my very first question. What are the options for augmenting a breast if that's something that someone's looking for?
Okay, so interestingly enough, there are, I would say, several options. The most common options are the ones that everybody knows about, and those are breast implant placement. And there's two basic kinds of breast implants in the United States. One in general terms is called a saline implant or a saltwater implant. That's an implant that has a surgical grade silicone rubber shell with a little port on it, and we put a little sterile tube in that port, and we infuse it with a sterile saltwater solution, which is the same saltwater solution that's in our blood. And we basically can expand the implant and size it accordingly and get really nice adjustments in size. Now, I haven't put a saline implant in since 2009. When the moratorium on silicone gel implants disappeared in December of, I think, 2006, patients just were like, put silicone implants in. But saline implants are quite nice in certain situations, like when you've got enough breast tissue to hide the implant itself, or if you are worried about perceived issues or complications or quote-unquote dangers of silicone breast implants. I don't like them so much because the way they're designed, they have a little ripple on the outside, and so over time, as the breast thins in front of the implant, you can start seeing that rippling, and it looks very porn starish. It's not very pretty. It's not very elegant looking.
What about to the touch?
They are saltwater. So saltwater actually is 10% weight for volume heavier than silicone gel, and so they have to be filled up pretty high, and so they have a much rounder, more unnatural lifted look to them. Very fake, but when you've got good breast tissue, you can hide that. But if you're a thin A cup, small B cup, these implants over time just end up looking very unnatural. And so they do feel firmer. You have to overfill your saline implants by about 20% to reduce the incidence of a particular problem called capsular contracture. Capsular contracture is a scar that normally gets placed around the implant that gets kind of wound up, and it starts to get thicker and thicker, harder and harder. It displaces the implant, can cause pain. I have an old patient of mine that I've been taking care of for about 12 years now, and I met her when I was a fellow in New York City, and she had had implants placed by a very, very famous New York City plastic surgeon in the 1970s. So I got to do her implant exchange, you know, in the late part of the early 2000s, and at that time she had grade 4 capsular contracture. What that meant is it looked like there was eggshell around her implant, and I cut my gloves open 4 different times during the operation just trying to get the old ruptured implants out to put in nice soft new silicone implants. And as you can imagine, she is much happier with these new silicone implants that she's had, I mean, almost 10 years now. So you know, that's something you like to avoid, but I will put a saline in if somebody wants one. In fact, there's a new saline implant called the Ideal implant. I'm not quite sure about it yet, but supposedly it has more of a gel-like feel to it because of how they've designed these various layers and chambers inside the implant. But I'll do a little research for you, and maybe we'll talk about that again.
What other options besides saline?
Sure. So the most common implant put in is a silicone gel implant. Now, silicone is an inert substance that is the gold standard for implantable devices in the human body. So when they're trying to figure out, you know, what you can put in, you know, like a titanium implant or a steel implant or a particular kind of plastic, it has to be at least as inert as silicone, medical and surgical grade silicone, to be able to be implanted in the body. So every time somebody draws blood from you, those little needles that are going in, they have a very tiny thin layer of silicone on them. That's what allows them to slide in and out of the skin very easily. And so you're getting exposed to silicone all the time. Silicone rubber implants, they're softer. They come out extruded in, varying sizes. So while if you've got, minor asymmetries in your breasts, those minor asymmetries are not as easy to correct with a silicone implant because they come out in fixed sizing, and it's not as easy to get that match that you could get theoretically with a saltwater or a saline implant. But the gel implants, they hang more naturally, they squish more naturally, they jiggle more naturally, and they really look and feel more like a woman's real breast. They feel fatty like a breast, and so they really give women and men really much more natural looking chest wall aesthetics and cosmetics.
Okay. What about, can you ever get the look of an augmented breast with someone's fat?
Well, so fat transfer, that's sort of the third option these days. Now fat transfer, it's a nice option. I will tell you the pros and cons of it. So the pro is you get a good liposuction out of it, which doesn't hurt. The cons are a little bit more extensive. One is really you're never going to get more than a cup augmentation. Nobody's ever been able to show in their literature and their before and after pictures that they can get more than 1/2 to a cup size. So it's not for a woman who wants that big vavoom breast augmentation that you see on social media and you see with celebrities and that sort of, I should say minor celebrities. Real celebrities don't do large breast augmentations. They use small, demure breast augmentations because they need to hide them for the camera, but they want to have a nicer match in their body, top to bottom. But fat can get you 1/2 cup to a cup size augmentation. Usually you want to support that with a breast expansion device. So in my practice, when I do autologous fat transfer, and I've only done 3 of them, that's not like it's not commonly asked for, but we'll do it if they ask for it. We all have people get a pre-expansion device. So the big one was a device known as the Brava, B-R-A-V-A. They don't make it anymore, but it would be this device that you wore on your chest wall and it would suck on your breasts for multiple hours a day. I actually like a device out of the UK called the Nuggleberry, and I'll put the link down in the description below in case you want to find a breast expansion device. Tissue expansion's been going on for decades. They do tissue expansion internally for cancer reconstruction and soft tissue defect reconstruction. Penis pumps are suction devices. They have nipple pumps and clitoral pumps and labial pumps, all for sort of sexual and or aesthetic purposes. This Nuggleberry, basically what you do is you wear it on your breast and you wear it for 30 minutes to an hour a day, and it creates a negative pressure. That negative pressure entices the body to enhance blood supply and soft tissue substance in the breast, and you can actually suction your breasts larger. Not tremendously larger, but larger. And usually when you see these women, instead of having sort of soft hanging breasts, they have more apical fullness with the Nuggleberry device or a breast expansion device. So I pre-expand the breasts for a few weeks before we do the liposuction and the fat transfer, and as soon as we feel it's safe, we put them on the breast expansion devices again to maintain and support those fat cells in the first 6 weeks when they're needing the most blood supply, when they're needing the most oxygen to really survive. And we've had some good results with that particular methodology of improving. But I mean, I would never tell you you're going to get a huge change out of it. The other downside, now, I think is a relative downside nowadays with modern X-ray and MRI technologies, but in the earlier days, the American Society of Plastic Surgeons was not a big fan of this procedure, and I'm not sure they're totally big fans of it yet, but they definitely said the big risk was if the fat cells die, they look like little calcifications, little calcium particles, and calcifications are an indication of breast cancer. Well, certain kinds of calcifications are an indication of breast cancer. And a good radiologist who's fellowship trained in breast radiology, who knows how to read a mammogram properly, who knows how to read an ultrasound properly, who really knows how to look at MRIs of your breast properly can tell the difference between a fat calcification from dead fat cells and a calcification related to an early breast cancer or a later stage breast cancer. So I wouldn't necessarily worry about that so much. The other downside is if you have fat that dies, now you're going to be feeling a lump. That might freak you out, and that might drive you to go to your doctor, and that might drive your doctor to order unnecessary biopsies, et cetera, et cetera, et cetera. But if you're good and your doctor's very conscientious and they basically get a good x-ray test beforehand to look at what your breasts look like under an x-ray like an MRI, then they can follow you afterwards. I always recommend that somebody who's going to get breast augmentation, who's getting closer to the mid-30s to 40s and beyond, have a baseline MRI or a baseline mammogram at the minimum, so your soft tissue characteristics before any type of breast altering surgery are known. And then I would recommend 6 months after any breast surgery of any kind, breast augmentation, reductions, lifts, whatever, anything that's going to put a scar around the breast, you get another, what we call new baseline test. And at that point, that baseline test is something that all doctors can refer back to look for changes. If you get a new physical exam change or you get a new yearly mammogram change that they're suspicious of, then they can look back and go, oh no, that was there. That wasn't there when she had her pre-op mammogram for her breast surgery. That was there 6 months after. We looked at it, we didn't think anything about it. Okay, this new one looks exactly like it. She's fine. Follow up in 1 year. And that's how you that's how you are smart about your own health care, and that's how your doctors are smart about taking care of you properly. But make sure your doctors know what they're doing. I mean, that's the biggest thing. Make sure you're going to a board-certified plastic surgeon. Don't go to an ER doc, like in the state of California, which drives me nuts. Anybody can do cosmetic plastic surgery. There's an ER doc in Southern California. He has an enormous practice. I don't get it. I get that they're physicians, but they were never trained to do this. And so they go get these weekend courses and just be careful. Just do your homework. Trying to go for the lowest price is stupid. This is your body. This is your life. Don't mess it up. What I hate more is when I have to give somebody a bill to revise their surgery that I never did, and it was much more expensive than had I just done it the first time correctly for them, and they had no problems. That being said, plastic surgeons have revision rates too. Talk to your plastic surgeons, ask them good questions. In fact, I've got a really good blog article that I wrote about how to choose a plastic surgeon. I'll put that link down in the description so you have something to focus on. You can ask your doc's questions, and you can be the most educated you can be before you have, surgery. It's surgery, you know what I mean? So be educated about it.
Yeah, for sure.
Yeah, absolutely.
What kinds of options does someone have in terms of choosing incision location?
Oh, yeah, there's actually a lot of different incision locations. I mean, the most common incision is the inframammary fold, so that the fold below your breast. It's a nice incision because it's hidden on direct view. It's the cleanest incision to go through typically. It avoids the blood supply, it avoids the nipple ducts. There is a little bit more risk of injuring the nerve to the nipples, but it's a 10% chance of hitting it. 90% of the nerve supply, in 90% of patients, the nerve supply to the nipples comes from the side of the breast, but in 10%, it kind of comes from the bottom midline. And you never know if you're going to be the 10% or the 90%, so it's a gamble. It's a 10% risk. So if we put the implant incision just a little off to the side of the midline, our chances of hitting that nerve are a lot lower. So that's where I tend to put the implant incisions, and that's a protective thing. And it's well hidden. Again, it's well hidden in the fold of the breast. Another nice option for people is the nipple areolar complex incision. Looks like a little smiley face between the color of the areola and the color of the skin. Now, it's a good incision because it's on the breast. You can wear the tiniest bikini and no one will ever see your incision. It can only be seen in certain people naked. The downsides are it's a bloodier operation. You're more likely to injure the nerve to the nipple. You're more likely to injure the blood supply to the nipple and cause nipple problems. And there's some weird scar characteristics called a trapdoor scar that can happen where it looks like it's an invaginated or wedged down scar if your doctor doesn't close the incision properly. The other downside of it, it does require you to have a very clear bordered outline to your nipple. Some women have those nipples that just, or nipple areolas that kind of just fade off into the distance. They're not good candidates for areolar incisions. You need to have a very clean circumscribed nipple areolar complex to have that margin, to have that incision in there. That being said, you also need to have a larger nipple areolar complex, especially if you're trying to put in a larger silicone implant, because you need to be able to make a big enough incision while maintaining the blood supply characteristics to be able to put an implant in that incision. So women with smaller nipples, not as easy to put those larger silicone implants in. Now, you can put a saline implant in of any size because those go in like little cigars. They get stuffed in through a tiny little incision before we inflate them. So salines can go through the tiniest incisions. Saline implants can go through the tiniest incisions. Another option is the axillary or underarm incision. Nice option as well, but the axilla is full of bacteria, and like the nipple, there are some risks of putting the incision in a bacteria-laden space. And one of the biggest problems is there is a reported higher incidence of capsular contracture, or that hard scar ball forming through nipple incision approaches and underarm incision approaches. And I will tell you, you're more likely to be sleeveless than you are topless. And if that scar is visible, every time you wave, it's easily visible to everybody. It's a harder incision to put in women of color who have a larger incidence of hypertrophic or thick scarring or dark scarring, hyperpigmented scars. So, very light-eyed, light-haired Caucasian females, probably a good option for them. Again, you have to worry about the higher rate of capsular contracture. The other problem with the incision is it is very, very far from the important target of releasing the inframammary fold muscle. So you're coming from here to release a muscle from here. At least with the nipple, you're only like a few inches, you're like a couple inches from the fold, and when you're at the fold doing the incision, you're right on the muscle, and you're able to release it so the implants have a good pocket to sit in. So oftentimes one of the biggest risks for these axillary incisions are that the implants tend to ride high, and sometimes that's the biggest problem and the biggest reason they need revision is the implant's high. That brings me to my other problem with the incision, is that it's very hard to redo a breast augmentation through that axillary incision. Once you've made it and you're trying to move implants around, trying to take them back out, it is much more difficult. And because of certain kinds of nerves that rest in that area, you have a higher incidence of getting pectoral sensory nerve injuries, causing numbness to the side of the chest and numbness to the inside of the arm. And I have to tell you, I have more people who I've heard complain about the arm numbness than nipple numbness. Huh. Yeah, there's something weird about how you walk or how you feel your t-shirts. It's unnerving to people. Right. So I would tell you I have probably done 4 axillary augmentations in my life, 10 or 15 nipple areolar complex incisions, and hundreds of inframammary folds. Now, there are a couple more. Everybody's heard of this through the belly button called the tuba procedure. It's quite an aggressive, it looks like a medieval torture type procedure where you're jamming this tube up through your belly button and trying to get into the breast from there. You can only put saline implants in there because you have to put the implant in through a tube that's tiny. You can't fit a silicone implant through that. So it's just for salines, and I don't do it. But there is a cool operation that I do every now and then, and it's called a trans abdominoplasty. So if I'm doing a tummy tuck on a woman, part of her mommy makeover can include a direct exposure through the tummy tuck flap into the chest wall, giving her basically scarless breast augmentation. Wow. And I've done a couple of those, and they have turned out beautifully. But it's a rare woman who can do it. You have to have a relatively short torso, have to be relatively small, and you're not putting in very large implants. It's just because it's a law. That's the ultimate distance incision. Like I'm going from a tummy tuck incision, a foot and a half up to a breast versus an inch or a couple inches from the breast. So those are your basic incisional options. I don't really know of other ones that are commonly used, but those ones are the most. But the inframammary fold is the most common incision used in any plastic surgeon's practice, unless they've marketed themselves as the tuba king or the axillary endoscopic, guru, whatever. Those are all the most common one's going to be the inframammary fold. So choose wisely because there are risks for all of them.
Now, what about placement? There's people need to understand what the aesthetics are, whether they're over the muscle or under the muscle. What goes into that decision?
Okay. In my practice, I'm a big proponent of making patients choose. I make you choose your sizes, and I give you parameters, and I even give you a little fun thing called the sugar test that I'll talk about in a minute. But when you're talking about placement of the implant, so 3 things we talk about in a typical breast augmentation consultation is, what type of implant do you want and why? What incision do you want to use? And what is your lifestyle like that would help me determine where I'm going to put the implant? Above the muscle or below the muscle? Now, above the muscles are called subglandular, and below the muscles are called subpectoral implants. The vast majority of women will get subpectoral implants. Why? They give you a more natural look in terms of the takeoff from your collarbone down over the breast and to the fold. You are less likely to have capsular contracture historically with an under muscle implant, and it offers more protection from rapid descent of the implant, and most importantly, there is a muscle layer between the implant and your breast tissue, therefore it makes it easier for you on x-rays to be able to delineate the breast tissue in case you're looking for breast abnormalities like breast cancer. However, there are a couple of downsides. In some women, when their natural capsule form is around the implants, when they flex their pectoral muscles, especially at the gym, those implants sometimes swing wildly in different directions, and they can almost dance around on your chest, and that can be very unnerving or socially embarrassing to people. If you're a very, very heavy lifter, like you're a CrossFit athlete, or you are a cop, or you are a Taekwondo expert, or you lift 70-pound boxes on the line at FedEx. I had one of those ladies, I can tell you that. That pec muscle's being strained so hard over and over and over again that it pushes the implants down and out, especially when you're thin. And so what that makes happen is your nipples then rotate in and up, and it looks like your nipples are cross-eyed. And it's a weird looking appearance naked. You'll look fine in your bras, and you'll look fine in your bikinis, but you'll look weird naked. And it's unnerving, and it does not photograph well, etc. So that's kind of how I decide on who gets subglandulars. Now, I like subglandulars for women who are definitely athletes, who need to get back to heavy-duty activities earlier, who are afraid of the pectoralis motion problem or the contraction motion problem of the muscles. But the downside is all you have now protecting your implant are your skin and your breast fat. That's it. There's nothing else. And so these implants can descend quickly in the women who, despite me telling them to, don't like to wear bras or don't like to wear support and want to jiggle and run around, with no support. Those implants have no support. Skin is not a good support device. Muscle is. And so they will descend faster if they're not careful. The other problem with those placements are the breast shape and characteristics then completely become the characteristics of the implant. So that implant, whatever height it is, that is where your breast will then start. So instead of having a nice smooth, travel of the breast, you have this travel where it basically goes from the clavicle, it's flat on top of your pec muscles, and then boop, you have a breast implant.
Mm-hmm. That's where you see a lot of the
that's where you see the edging.
Upper edging.
Yeah. So Victoria Beckham,
right,
perfect example.
Exactly.
She's so darn skinny, and she's pretty, but she's so skinny. And whatever implant you put in her, you need muscle control, and so all those you need muscle protection, coverage. You need muscle coverage. But those old pictures are from her from a year, years ago. She had very, very etched implants. Mm-hmm. So for her size, I don't know if she had saline, I don't know if she had gel. She's in the UK, and I'm assuming she had her procedures done there. And there they've had gels for decades. Now she looks much smoother if you see her. So something's changed in her augmentation, and I think she probably had an above muscle augmentation. Don't quote me, I don't know for a fact. So yeah, the best way to avoid that etching is to put the implants under the muscle and not go so egregiously large that the implant then dominates the soft tissue characteristics.
Okay. What about under the muscle. So you mentioned that someone who wants to get back into the swing of things very quickly, you would use over the muscle. So it's a much bigger recovery time for under?
Typically, yeah. I tell people with above muscle implants that they can get back to cardio with double sports bras at about 2 weeks, bouncing, that sort of thing. And at 1 month, they can do full weightlifting. I double that for under the muscle implants. They go 4 weeks before they can do any bouncing cardio with double sports bras. And once you get breast augmentation, unfortunately, you need underwire bras because you need something to fix or affix that inframammary fold in the perfect position so the implant can descend naturally around that fold. That fold is what determines everything in the breast.
Mm-hmm.
And so your first bra when you wear it should be an underwire, and then you wear a tighter non-underwire bra on top of that to support you. So if you want to be a runner, that's what you have to do. Or you put in tiny breast implants, or you do fat transfer and get a little bit of augmentation that's very, very natural, and then wear an appropriate sports bra when you run. But for them, they only get to weightlift at 2 months, past 8 weeks after their surgery. So because those pec muscles need some time to scar back down and heal. And the biggest thing after, in terms of immediate recovery, lots of muscle spasms for the under muscle augmentations or the subpectoral augmentations. So we give everybody Valium so that those muscles are not so tight. It can make you feel like you can't take a nice deep breath. And that's one of the biggest complaints. So like, there's an elephant sitting on my chest, or man, I can't take a deep breath. And that's the muscle spasms. The subglandular patients, they don't complain about that. They look fantastic when they come in the office. They're like, barely hurts.
Really?
Yeah, it's like a night and day difference between an under muscle implant and just these subglandulars.
Yeah.
They look like I didn't do anything to them.
All right.
So
well,
it's deceiving. It's deceiving, but most people I'd recommend under muscle. Just it's got more benefits to it long term, which is really what you're looking for.
Okay. Well, we touched a little bit on exercise restrictions after. Let's talk about what can I expect for recovery immediately following surgery up until I'm kind of free to do my normal activities.
Yeah, I mean, for most people, it kind of depends on what you do for a living. I mean, if you have a desk job, if you're not taking pain medicine, you can switch to Tylenol. You can get back to your desk job within a week, typically. The big thing with implants is especially under muscle implants, they start high. So it always freaks out a patient. And I tell them, don't worry about it. Natural motion, gravity, maybe the wearing of an apical band or breast exercises will slowly get those implants to descend over time. And so they may start high, but they'll fully settle in within 3 to 6 months. And one of the other things people tell me about is, or what they admit to, is that it may take up to a year before you forget that you've got breast implants in. Like you will be aware of them when you're turning around in bed, or if your partner or spouse touches your breasts. So it takes a while to personalize and negate the fact that you've got implants in emotionally and like psychologically. So it does give people time to do that. But really, if it's subglandular, you get back to things pretty quickly. You can get back to work, you can get back to lifestyle. You can do basic lifting quickly. Mm-hmm. So like, your activities of like, picking up your laundry basket or picking up a pan or sweeping or whatever you might do in your own home to take care of your domicile. Those things you can do earlier with the subglandular, because the pectoralis muscles are involved in almost everything. It's amazing. You do need to take it a little bit easier. I don't let people do lift more than about 5 to 10 pounds in those first couple of weeks, just so that they're not straining those muscles. Mm-hmm. But yeah, you can get back to most of your basic activities within 7 to 10 days.
Okay.
Yeah, it's not bad.
It's not. With this millennial generation and selfies and all of those things, I think that generation probably feels a lot of keeping up with sort of feelings.
Like the keeping up with Joneses?
Yeah, or the Kardashians.
The Kardashians, right, keeping up with the Kardashians, that's right.
What is the youngest patient that you would feel comfortable doing an augmentation on?
Well, interestingly enough, it depends on who you're following. The American Society of Plastic Surgeons recommends breast augmentation in no one earlier than the age of 22. I'm a little unclear on that age. It seems a bit arbitrary for me. Mm-hmm. I believe that the reasons for it have to do with potential incomplete growth of the chest wall, maybe lack of maturity in somebody less than 22.
In decision making.
In decision making, exactly. Questions about whether they will or will not have children and how that might affect breast augmentation, etc. Now, the youngest breast augmentation I've done has been on an 18-year-old. I've done 2 18-year-old patients. The first, she was an exotic dancer, and she had a child, and she had a very supportive mother and family members. And so she knew what she wanted to do. She had done her research. I further educated her. She had a great breast augmentation and has had no problems with it. She follows up like she's supposed to for her exams. And so she's been consistent. And so I think because she was a young mother, she was far more mature of an 18-year-old than many 22-year-olds who I knew in college and I know now. So I didn't think it was an issue for her, and she had the appropriate support and connections. The other young lady had family support, and her big issues were her breasts were so tiny compared to her hips that she couldn't buy clothing, and she felt very uncomfortable in the gym. And so it's no different when you have a 6-year-old child with, Dumbo ears who starts getting teased in first grade when other kids are starting to become perceptive of the other. You are, as a parent, are going to get that kid a notoplasty, right? And so you're going to get his ears pinned or her ears pinned. That's 6 years old. That's elective surgery. But it's for psychological protection, support, and improvement. So I don't see this as anything differently, but the party line is 22 and above.
Okay.
Yeah.
That's good to know.
Yeah.
It's interesting to know. I think we've kind of covered most things. Is there anything that you can think of that you want to add?
Yeah, I think the important thing is, the interesting thing about breast augmentation is once you do it, you are forever bound to future surgeries, all right?
Yeah.
So it's not like it's not a one and done thing, and I don't know where this concept of one and done has come up in cosmetic surgery, but I have to unteach everybody about permanence. There's very little that's permanent in plastic surgery. Why? Because you age. Why? Because you're putting in artificial implants and devices that have limited lifespans. Once you start this road, you'll be on it forever until you decide, no, I don't want to do any more breast surgery. So, what could happen? Okay, you get your breast augmentation when you're 25 years old, fine. Well, let's say you go through and you go and have cyclical weight gains and losses, or you get pregnant, you breastfeed, you go through hormonal changes, blah, blah, blah. You'll go through all these things. Your breast implants are going to be there the whole time, but your body's going to change around it. That may necessitate further breast surgery. You could pop a breast implant, got to put it in. You could get, or you got to change it out. You get capsular contracture. You got to fix that. Once you get a capsular contracture, it sucks. You're always at risk for capsular contracture in the future. So just understand, don't think that this is a one and done, and it never is. Just be ready, financially be protected, know what you need to do. These implants come with great warranties. They can protect you against certain kinds of defects and problems. You get free implants and you get money towards anesthesia and facility charges, but you have to meet criteria, so just be prepared financially for this procedure. I think it's one of the procedures that has more cost to it long term than I think people are cognizant of. When you do a nose job, that's permanent. That's why I do a tremendous amount of nose surgery, because it's typically one and done, and I have such a low revision rate that I don't have to do much touching up, and I've never had to do a major revision of any kind. So, but breast, no, that's an annuity. It makes you keep coming back to your plastic surgery over and over again with time. It could be your nipples got splayed, or you don't like a scar, or I'm having pain in my nipples. Be ready, all right?
What about just the shelf life of an implant? Say you're not having any outward issues. What about how long can you safely keep an implant in?
I mean, really, the risks of implants in terms of rupture and other problems tend to start increasing between the 10 and 15-year range. That being said, that's on older data. The newer data is showing even better long-term longevity in terms of complications. So I've had patients who are 17, 18 years old with silicone implants, and they have zero complications. They're soft. I will call them a grade 0 capsule. I know it's a grade 1 capsule. Malleable, both in the same position, look fantastic. And you know, there are going to be people who are outliers. We just tell people, when you're getting towards that 10 to 15 years, definitely come in, get evaluated. I will tell you this, as your implants get older, the risk of rupture from mammograms definitely goes up. And so I recommend against mammograms as your test, not because I don't recommend mammograms. I love mammograms, you need to get tested. But they put a lot of pressure on those aging implants. So I recommend for breast implant patients the use of MRIs. And let me tell you why. When you use a mammogram, there are a couple of downsides. Well, ask any woman who's had a mammogram and ask them if it was a painless outcome. No, mammograms hurt. They have to squeeze your boobs between glass plates, and if you've got dense breasts, they've got to squeeze harder. Well, those implants are getting squeezed under those glass plates, and they can be squeezed enough to rupture them. I've taken care of 3 individuals that ruptured within 3 to 6 months after mammograms, in the last 2 years. And so rupture is something that you have to be worried about. And you'll find out that when you're signing your consent forms for your mammograms, there's a box that talks about breast implants and talks about how mammograms can rupture breast implants, and that you are not going to be able to come after them for money or damages because of the mammogram. Number 2, mammograms do miss breast tissue segments and areas in implant patients. Traditionally, you can miss up to 30 to 40% of your breast volume with a standardized mammogram. Now, using specialized mammograms like Eklund displacement views and 3D mammograms, you get better overall visualization, but you may still miss 10 to 15%. So if you've got a breast cancer starting in that 10 to 15%, you're going to be awfully unhappy that mammogram didn't pick it up. So I like MRIs. Why? They're the gold standard for detecting breast cancer and basically any other breast problem. They have 0 radiation, so you can do them for every day for the rest of your life. They use magnets. Now, if you have metal plates in your head, or if you've got a lodged bullet or buckshot in you, you can't have an MRI. Anybody who's gotten metallic implants of certain kinds are not capable of having an MRI, and you'll have to have a mammogram. But if you're not one of those people, an MRI is fantastic because it sees 100% of the breast. 100%. It misses nothing. And there's no squeezing of your boobs. They put your breast into something called a breast coil, and they basically do the MRI with magnets, and they see 100% of the breast and miss nothing. And you're not having your breast squeezed, so there's no rupture risk with an MRI. The downside of an MRI is you've got to be in that tiny little tube, and so if you have claustrophobia or you don't like small spaces, MRIs are going to be rough. So in those cases, I usually ask the question to my patients, and if they have an issue, I give them a small, short prescription of Valium. You should ask your doctors to do that as well. Take the Valium 30 minutes beforehand, maybe 10 milligrams for the average patient. You'll be stoned for half a day, but you will be chill enough that you don't freak out with your arms up inside the MRI machine and the breast coil on. Yeah, definitely. Now, another practical problem with MRIs, however, is that very rarely will your health insurance company cover the costs. So I just tell people this is part of the ongoing cost of maintenance for a breast implant. Every year, put about $500 to $600 aside, because most out-of-pocket cosmetic MRIs, which are exactly the same as the insurance kinds, they're read by the exact same very professional, very intelligent breast radiologists, but your insurance company will not cover maintenance MRIs. So you cover them. $500 to $600 per year in a jar, put it away, break into it only in the case of emergencies, and get your MRIs and follow your breast implants along. That's how you know if you're doing well. Because when a saltwater implant ruptures, it looks like a deflated tire. You totally know that there's a problem. But if a gel implant ruptures, that gel's stable.
Yeah, that's what I was going to ask you. How do you know if a silicone implant has ruptured?
You don't. Sometimes you can't tell. the implant will look exactly the same because of these modern form-stable gels. These modern gels they're not like honey. Like the old silicone looked like honey. So you can make a cut, squeeze the implant, and you'd be squeezing, liquid silicone honey out of the implant. These modern implants are more like the gels in your running shoes. So they are cohesive gels. They stick together like a mass of rubber, like very, very thick, congealed honey, So you can cut an implant like a piece of pie and hold it up, and it'll sit there in your hand like a piece of pie, only it's squishy.
Yeah.
Right, yeah, so these new implants, they're not made as much out of silicone oil as they are made out of cross-linked silicone polymers with a tiny bit of oil in it. So they're far less inflammatory, they're far less problematic than implants from 20 plus years ago. So, however, because of that form-stable gel, if you get a cut in the implant, you can't tell. It'll look exactly the same. However, certain kinds of radiology testing can pick up things like the spaghetti sign and stuff like that look like weird waviness on x-ray that can give you a sense that you have an implant rupture. Now that being said, I've gone in on people who swear they have ruptures, but all testing said no rupture, and they were ruptured. Right. So, the best way to figure out a rupture is to make an incision and look at the implant.
Okay. I thought of one other thing that we sort of skipped over, and that is figuring out, how do I figure out the size that's best for my body? How do I figure out the size I want when it's kind of, it's on the outside of your body. You don't really know what it's going to look like once it's on the inside. And you mentioned a sugar test, I think you used for people to help decide.
Yeah, so, because of the fact that the nerve to the breast in 90% of patients comes in from the side, to avoid the complication of nerve injury from too large of an implant, we try to use the breast width, each individual's breast width, as sort of our container size maximum for the implant that we want to put in. And we use that, what they call base width, to then determine where we go in terms of implant sizing. So, in the world of implant sizing, we have this particular concept called breast implant profiles. Now, a profile basically is a combination of a width and a projection of the implant that leads to a certain volume. So, I tend to prefer using Mentor implants. It's not a plug for the company. I just have really enjoyed their implants. But there's 3 major companies in the United States, Mentor, Allergan, and Sientra, who all make wonderful products. That's the end of my soapbox on it. There are 4 different sets of profiles in the silicone realm for Mentor smooth round implants. I don't typically put in shaped implants. That's a totally different conversation we can talk about in a minute. But when you have an implant, you have a certain base width and a certain projection. That gives you a certain volume. When you're, let's say, a narrow-chested woman, you can't put in a very wide implant, but let's say you want cleavage. Well, you want a breast implant that's a little narrower but has more projection. So that means your profile is going higher. So you've got 4 basic profiles: moderate, moderate plus, high profile, which is the most common implant I put in. And then I've been noticing more women coming in who actually are requiring ultra-high profile. So that means that when you're moderate, let's say you want to put a 300cc implant in, okay, just the same volume. When you have a moderate implant, you've got a wider base and a shorter projection. So those kinds of augmentations are very natural, very full, and not overtly done. So you can dress them up or dress them down based on the bra that you wear. But let's say you're narrow-chested, but you want that same 300cc implant based on how tall you are, or this sugar test that I'll describe in a minute. Well, I can only, let's say I can fit in a 10 centimeter implant. Well, then I need a higher projection to get that same volume. So I'll put in an ultra-high profile implant that can fit in. So based on chest wall width and volumes that I need, I will give you different projection options that we can pick. But the first question is, what volume do you want? And so everybody's got their own way of doing it. I call mine the sugar test. It's very simple. You need granulated sugar, and you need those little 30cc Tylenol liquid medicine cups that you get with a bottle of liquid Tylenol. 30 cc's is an ounce for those of you who don't understand SI units. But 30 we talk about breast implants in cc's or milliliters. Cc's are the same thing as a milliliter. A 30cc cup of sugar placed into a Ziploc baggie starts you off on your implant size choice. So let's say, when you come to see me, based on your measurements, I will give you a range of implant options from moderate profile, if it even matters, all the way to ultra high that goes along with your idea. So I'll give you an ideology of 4 different start points for implants. You're going to go home and you're going to get your Ziploc bags out, 2 of them, or at least just 1, and you're going to start with the lowest. You're going to start with the number of scoops of sugar that I recommended, at 30 cc's for the lowest implant. Let's say I said the smallest implant we could put in was 300 cc's. Well, that's 10 of those little Tylenol medicine cups. 30 times 10 is 300. So you put 10 little sugar cups in there, you de-air it, and you Ziploc the bag. Warm it up, move the sugar around, put it on your breast, put a bra on and wear a very tight t-shirt, and walk around for 20, 30 minutes looking at yourself in the mirror with what a 300 cc implant would look like. Then you go up from there. So let's say the next one was 420. You put 4 more cups in there. 14 little cups total, that's 420 cc's, and so on and so forth, until you find an area of volume that you like enough. Then we come back at a pre-op and we talk about that number, and then I find an implant that pushes that boundary properly. Now you're going to say, well, why are you pushing the boundary if I like 420? I push the boundary because a lot of times women, when they come in, will find that they boiled it down to 2 sizes. The one that's just perfect, but the one that they like better, but the number freaks them out. And I usually tell them, go with the higher volume, go with the larger implant. Why? Your natural breast tissues are going to thin out and get smaller because the implant puts pressure from behind on those implants. That's called breast tissue atrophy. And that breast tissue atrophy basically makes your initial augmentation look too big, but then you're like, come back and like, well, geez, now I look too small. And the number 1 reason for uncomplicated revision breast surgery is they want to go bigger. 51%. So I think I've done 1 size reduction and 2 enlargements in my whole career. That's it. Because I make patients pick, and they are very happy with their choices.
Right.
So given these 2 options of, these are your 4 basic starting sizes, and try the sugar test, the average woman can come back and find a good size. Sorry, I need to get a little drink.
What do you tell women who haven't had their children yet and still want to have an augmentation? They don't want to wait all those years, but they maybe want to breastfeed. So what do you tell those women?
Interestingly enough, a lot of women that get breast augmentation are young. They haven't had children and they don't even know what their breastfeeding capabilities are. Don't worry about how your sister breastfed, twins at the same time, or your mother had, made so much milk that she could freeze it all, in a separate refrigerator. You do not know how much breast milk you're going to make until it's your turn to make breast milk. And so I tell patients this: that's not a reason to not have a breast augmentation. It's not a reason to feel good about yourself, or to not feel better about yourself if breast size is something that weighs heavily on your mind and spirit. Get a breast augmentation. It does not prevent you from breastfeeding. But I do tell people, if you really do want to breastfeed, just for safety, just for low risk, put the implant under the muscle. It's easier that way.
Okay.
You're less likely to damage any surrounding breast ducts and potentially increase the risk of decreased breastfeeding capability. But from the literature, there's no indication that breastfeeding is altered by the placement of implants. It's just the surgery to put them above the muscle might actually damage the breast glands. But when it goes under the muscle, there's no damage to the breast glands.
Okay. Now, if there is anything that our viewers have questions about that we haven't answered, can they ask the questions below? Yeah, seriously. So in the comment section, I love this stuff. So if you have questions or comments, please put them down below. I'm happy to answer anything, and I'll give you quite a good answer. You'll see what I'm talking about. If you like this vlogs, or I should say, what do my kids tell me? They're not called vlogs, Dad, they're vlogs. Yeah, if you like our vlog, please subscribe, please share. We want to be able to educate people, and I think this is a great way to do it, and I'm no nonsense about this stuff. How you see me here is exactly how you see me if you come into one of my office consultations. I don't believe in this hype that you see in social media. You'll never see me in my Armani suits. You're never going to see me
rocking bling. I'm not going to have myself sitting on a beach. I do those things, but that's not what plastic surgery is. And I know that's really interesting to patients, but being a plastic surgeon is not just that. It's a lot more than that. And I take what I do very, very, very seriously. It's a sacred responsibility to take care of patients. And so I want you to understand that's kind of how I look at this. And education is the key to safety. It's key to success in plastic surgery.
Yeah, for sure.
Yeah.
And if there's any surgery or aesthetic procedure that you guys are interested in hearing about, leave those in the comments below too, because we'll do one coming up.
Yeah,
and
we love doing this. It's so much fun for us to do. It's very easy to do, and so education for me is a big thing, and I'm happy to talk about anything. I'm happy to dispel rumors. I'm happy to debunk, the most recent fad. I'll teach you what you need to know about stuff so you can make good decisions for yourself.
Mm-hmm, for sure.
Yeah.
Okay, it's time for the real self question of the day.
Real self question of the day.
And Dr. Shah doesn't know what I'm going to ask, so.
So let's see if you can stump me with something.
All right. This patient or potential patient says, I quit smoking almost a year ago. Recently, I've been going through stress and had the urge to smoke again. Instead of smoking, I started back on nicotine replacement therapy. I use Nicorette lozenges about 3 to 4 times a day. How soon before surgery should I stop?
Okay, good question. Why is nicotine, first, the way I would say this, why is nicotine a problem? Now, smoking, let me add something I found out recently. Smokers have reduced vitamin C levels. So a lot of doctors actually recommend that if you're a smoker that you take vitamin C supplements. About a 15% reduction in your vitamin C levels. So that means that may be why smokers don't age well and their cardiovascular systems are
their collagen is
breaking down. They get smokers' lines and wrinkles. So think about that. Bump up your vitamin C intake if you're a smoker. All right. So let's get to the concept of nicotine. Smoking cigarettes obviously is a nasty habit, but it is what it is. There are tons of nasty chemicals and cancer-causing agents in there, but from a plastic surgeon's standpoint, nicotine is the prime problem, and that problem is that nicotine is a vasoconstrictive agent. So it takes blood vessels and it crushes them closed. So if you've got an incision, if you've got a large flap, if you've lasered the face, and you need good blood supply, if you have nicotine in your system, you are basically jeopardizing that blood supply, and it's very common that smokers have very severe complications, not only from elective cosmetic surgery, but non-elective surgeries. Their wounds break down in abdominal surgery. They have a hard time getting off the ventilator because the smokers cough and they don't get as much oxygen. There's a lot of problems. So the nicotine needs to stop about a month beforehand. So the last time you smoke a cigarette, or the lase time you use your nicotine patch or Nicorette gum, 4 weeks before elective surgery, because you can actually detect that last nicotine for up to 30 days.
Really?
And there's a test that plastic surgeons will use, whether you know it or not, on the day of surgery when they're drawing blood, that will test your nicotine level if they're suspicious. And they will turn around and they will cancel your breast reduction and your tummy tuck and your body lift and your thigh surgery and your facelift. All very expensive operations, all very long recoveries if they find nicotine in your system. So that sucks. You've already taken time off from work. You've arranged for somebody to care for your kids. You've used up vacation days that you can't switch. And they cancel you because you couldn't keep it together long enough to stop smoking or stop your nicotine. So that's what you need to do if you want to have safe surgery. And that's what you need to do in my practice. It's very rare that I will allow any type of nicotine in my practice unless it's very particular operations where it's not going to cause me complications. But nicotine gum is not going to cause pulmonary complications for general anesthesia. But if you're smoking a half pack a day or a pack a day and you're going to go for general anesthesia for elective cosmetic surgery like liposuction, you're going to have a complicated post-op recovery from the anesthesia side of things. So be ready. It's elective surgery. Don't add more risk than necessary.
Exactly.
Yeah.
Okay.
All right, well, thank you for thank you for joining us today for our second episode of Cosmetic Surgery and Coffee, Breast Augmentation, All You Want to Know. And so stay tuned, we'll be putting more of these videos up. Subscribe if you like what you see, share in the comments below, ask your questions, pitch new show ideas for us, and we hope to see you soon. So this is Dr. Shah signing off, Miss and Misti.
Bye-bye.
Bye guys, take care.